Welcome everyone. We're going to go ahead and get started as everyone starts to join. We have a very exciting talk today. I'm so grateful for our speaker for coming out here to talk to us. So we're going to introduce her. This is Dr. Carol Weitzman. She's a developmental behavioral pediatrician and the co-director of the Autism Spectrum Center at Boston Children's Hospital and director of the CT Center for Developmental Pediatrics, the Connecticut Center. She is an associate professor at Harvard Medical School and professor emeritus of pediatrics at the Yale School of Medicine. While at Yale, Dr. Weitzman was the director of developmental behavioral pediatrics and oversaw the fellowship training in developmental and behavioral pediatrics. Nationally, she is a past president of the Society for Developmental Behavioral Pediatrics, a past chair of the American Academy of Pediatrics section of Developmental Behavioral Pediatrics, and a member of the American Board of Pediatrics Subboard.
And Dr. Weitzman is the author of the American Academy of Pediatrics Clinical Report, Promoting Optimal Development, Screening for Behavioral and Emotional Problems. She is currently conducting studies to understand the healthcare experiences of people with neurodevelopmental disabilities and a multi-site trial to train primary care providers to diagnose young children with autism spectrum disorder. We are thrilled to have her here today and really thrilled to have her talk about her important work on the Supporting Access to Care for Everyone, or SAFE initiative, which provides guidelines for improving healthcare equity for youth with neurodevelopmental disabilities. Please help us welcome Dr. Carol Weitzman.
Hey, good morning, everyone. Can you hear me all okay? Perfect. All right, I'm really delighted to be here. I thank you very much for the invitation. Thank you. And I'm very delighted to be here to talk about a topic that is very meaningful to me. I have my name on here, and I also included my Dr. Cy Nadler, Dr. Marilyn Augustine, because we've worked very, very tirelessly together on this topic, on this project, and I'm very happy to talk about it with all of you and hopefully have enough time to have some conversation and questions and ideas. So let's see. Oh, I guess use the mouse. There we go. So I have nothing to disclose. I will say, and you'll hear about it a little bit, our funding for this project, some of it came through the Maternal and Child Health Bureau, and that is going to be important as you hear some of the things that I tell you that as we go on. So this is what I want us to try to accomplish this morning. We're going to talk a little bit about the state of healthcare delivery for youth with neurodevelopmental disabilities. And I hope that as I talk about that, you'll understand why the SAFE initiative was born, if you will. I'm going to describe the SAFE initiative, the key domains that healthcare settings need to consider to improve care access and outcomes for youth with NDDs and their families. And I'm very excited to be spending today and part of tomorrow with you, talking about it at your center, which is really fabulous. And then, as we sort of talk about what SAFE is, we want to talk about opportunities, priorities for medical education, clinical dissemination, advocacy, and research to support the healthcare of youth with NDDs. And I know in this audience, this is stuff that you all think about all the time and is near and dear to all of you. And so it's fun to talk to an audience that I know gets it. I'm going to start with a video. And let me just tell you who this is. This is Ellen Bannister. Ellen is a parent. She's a professional advocate from Oklahoma, and she's going to tell you the story. You're going to hear the story of her son, Ben, who has intellectual and developmental disabilities and is on the autistic spectrum. And as a grade schooler, he required orthopedic surgery on both of his legs. And she has allowed us to share this story. And I think that, sometimes I always say listening to people's stories is far better than me telling you about their stories. And, well, let's give it a go.
Preparing for this surgery, we asked if anyone had ever pulled off their casts, as Ben cannot stand to even have a Band-Aid on his skin. We were told it wouldn't happen. When I asked if we would need home health services after the surgery, we were told we wouldn't need them and that our insurance wouldn't pay for babysitting. We asked if he would need a wheelchair and were told no. After the surgery, we took Ben home with split casts up to his calf and long incisions along his ankles. He couldn't walk, so we found an old transport chair of my grandmother's in the garage to use. While he was sleeping, I showered in the bathroom next to his bedroom. I left him alone sleeping for 10 minutes. When I checked on him after my shower, he was lying on his bed in a pool of blood. Within that 10 minutes, he had pulled off his casts off his legs and pulled out both incisions, which were now completely open. I didn't realize it until years later when I was taking a Stop the Bleed training, but if I hadn't gone back in when I did, Ben would have bled to death in a few hours. The ambulance took him to Children's Hospital, where he was given ketamine for the first time. It turned out that he was allergic to ketamine. His skin became red and covered with hives, and he began convulsing as they tried to stitch up his legs. 6 people were trying to hold him steady, including me, his dad, and cleaning staff who had been called in to try to help. Ben was not admitted after the stitches and makeshift bandages were done, and we were too dazed to try to argue. We were given no follow-up instructions that I can recall. I asked what we could do to stop it from happening again, and the resident who was providing care said he didn't know. I asked if duct tape would work, and the resident said maybe. We kept our heads down and endured. It was only later, after we spoke to other families with similar post-surgery experiences, and found out that these events are fairly common for kids on the autism spectrum.
Okay. So you hear a story like that, and it's horrifying, isn't it? And there's just so many things that went wrong in this child's care, from the planning, from knowing and understanding what his post-hospital needs were, to pulling in people like the cleaning staff to help with, holding this kid down, to being highly dismissive of the parents' concerns, to a resident saying, it's okay to say, I don't know, but like, should I use duct tape? Sure, give it a shot. There are just so many things went wrong here, right? It's very tempting to hear a story like this and think, well, that must be one lousy children's hospital because it would never happen here. And the truth is, this kind of stuff, maybe not to this extent, thank God, but maybe not to this extent, but this kind of stuff happens all the time, every day, all over the United States, for some reasons that we're going to talk about. And that's what we have to try to start to understand. Why on earth would something like this happen in this way? And again, we all like to think, well, it wouldn't happen here. And the answer is it does. It does, again, I hope not to this extent, but these kinds of stories happen everywhere, all the time, every day. So let's just do a little bit of understanding about the context and how common are problems of children. Again, I know I'm talking to a group of people who understand this very well. 1 in 6 youth have a neurodevelopmental disability, and they face higher rates of medical complexity. And there was a paper that just came out with looking at the National Survey of Children's Health. More than 40% of youth with medical complexity are on the autistic spectrum. And when you look at kids on the autistic spectrum, about 60% have medical complexity. So there's a very strong relationship between medical complexity and neurodevelopmental disabilities. That makes sense. But yet, despite that high level of complexity, we know that children have increased barriers for accessing medical care. They have much less preventive well care visits, and more challenging accessing care. So you see a lot more foregone care. So that's not a good combination, is it, to have a lot of medical complexity and then have difficulty accessing care? And what happens then is what you see is that you see that people have worse long-term health outcomes and higher rates of morbidity and mortality. And obviously, this combination just has very significant impact on, health and well-being during childhood and into adulthood. So I'm going to show you on the next 2 slides just a little bit about those mortality and morbidity rates, just to put it in context. So the people with autism are 2.5 times more likely to die than people have a 2.5 times higher death rate than non-autistic people. And on average, they die about 20 years younger than their non-autistic peers. And children and young people have a 12 times higher risk. So it's very elevated in childhood. Females are at greater risk than males, likely due to co-occurring intellectual disability. And this is sort of important when you look at this. The leading causes of people with autism who die early without intellectual disabilities, these are the most common causes. Neurological disorders, including epilepsy, suicide, accident and drowning, and diseases of the circulatory system. So I think there's sort of some interesting take-home messages to me in those causes of death. Number one is we do know that people with neurodevelopmental disabilities with autism will have more medical complexity, but often they will present for care much later on. So they have more advanced disease, more times where there's been things that could have been addressed are not, and so they present often with more significant morbidity, more higher risk for mortality of those. And then what you see is that there are often many preventable causes of death, the suicide and drowning, things that may be unaddressed mental health needs, so that place children with autism at higher risk for morbidity. And then again, the diseases of the circulatory system, again, while there may be higher rates of underlying cause, not treating early, not having access to care places people at risk for higher mortality rates. Okay, and this slide is looking at people, adults with intellectual disability. So what you're seeing here is a busy slide, and I'm going to just orient you and just sort of look at what our take-home points are. This is looking at these adjusted odds ratio for very specific causes of death for adults with and without intellectual disability. And this is based on a very, very large sample size. Okay, so first, just to orient us, number one, the difference in age of death for people with and without intellectual disability does have some variation by severity. This kind of lists it through mild, moderate, severe, profound, unspecified. Don't get too hung up on this in the slide. We're going to just look at it more globally. But when you look at people with mild to moderate intellectual disability, they are likely to die 10 years. Their age of death is 10 years earlier than people without intellectual disability, and severe and profound close to 17 years earlier. What you see here is if you look down across all of the different sort of categories and specific causes of death, anything, if you will, to the right of that line suggests that people with intellectual disability have a higher odds of death from that cause. Not everything is to the right, but a whole lot is. And a whole lot is to the right, even for people with mild intellectual disability. Again, it's the interplay, I think, between complexity and access to care. All right, and when we look at youth with NDDs in pediatric hospitals, what we know is that autism is among one of the most significant predictors for prolonged mental health hospitalizations. And now we know, and again, I'm sure I don't have to tell all of you, that mental health admissions account for about 20% of all pediatric hospitalizations now. I think we saw a huge spike during COVID for that, and I don't think it's really come down since then. So everybody is aware of this, but autism predicts, again, prolonged mental health hospitalizations, prolonged length of stay. And there's multiple reports of increased rates of physical and pharmacologic restraints during hospitalization of autistic youth. We did a study and looked at this, and what we found is that people with autism on pediatric units, not in psych units, this is just plain old pediatric inpatient units, were more than twice as likely to be restrained, even after you accounted for behavioral health problems. So just having autism was a risk factor. And again, despite the expertise, psychology, developmental behavioral peds, psychiatry struggle to identify and respond to suicide risk for autistic youth. It is, again, if you looked at the earlier slide, why we see higher rates of suicide, and they are higher, the rates of suicide are higher in people with autism than they are in neurotypical youth. And we really still haven't found appropriate measures to be able to detect this well, to respond to it well, and so we see this. So again, behavioral health, developmental, and cognitive delays are among the most common conditions that are associated with aggression towards healthcare personnel. And this really ends up playing a lot into those restraint rates because people become afraid of caring for kids with NDDs. And they kind of then have a bit of a go-to to use things like restraint and seclusion to address behavioral problems. And so that is a lot of, where we started to feel like there has just got to be a better way that we are working with people with NDDs in healthcare settings. That this is not something we should get used to. This is not something we should tolerate. But then we have to say to ourselves, well, why do we? Why have we to date? What underpins this? Because it's a little weird, isn't it? That like you would see this and see a video like that and that it wouldn't, cause major alarm bells. So like, how have we gotten to this? And I'm going to show you what I think are sort of at least two of the main things that underpin some of this. Number one is education. In general, healthcare professionals across all of healthcare really report significant gaps in training related to NDDs. I do think this is changing. I don't think we have a choice but to change this when I tell you that 20% of hospitalizations are kids with mental health problems, and a large cadre of those kids are people with NDDs, neurodevelopmental disabilities. We are seeing more and more kids who are entering the healthcare system, entering inpatient stays. So we don't really have a choice. But traditionally, there's been real gaps in training. I will tell you that one of my colleagues, Dr. Augustin, went to the ACGME, had a big disability summit, and they are very serious, actually, about trying to improve education in NDDs for medical students across all branches of medicine. So I think there's change happening. Few pediatric hospitals embed optional, let alone mandatory or ongoing education for staff. And that includes all staff, from the minute someone drives into your parking lot till the minute they leave, should have some knowledge of what it means to care for people with NDDs, people who greet you at the door, people who help you park your car, people from the second you touch the healthcare setting to the second you leave. So that is including a lot of folks. And people have thought about this, but not in a very, global way. The long-term impact of educational interventions are largely unstudied, and there are major barriers to representation of people with NDDs in healthcare professions. So that's one. The second is what I would call is that I think we need to talk about is ableism. So ableism is really the discrimination against people with disabilities and undervaluing people with disabilities and ignoring the unique needs of people with disabilities. This can occur at the individual level, and it can occur at the structural level. So at the structural level, what I'd say is it is discriminatory processes and policies that systematically privilege able-bodied people and fail to represent or meaningfully include disabled persons' voices. Now, most of the time, it's not a conscious thing, right? I don't think most of the time people are sort of, setting out to discriminate against people with disabilities. But there is a lot of unconscious bias, and that's what we need to be able to do, is lift that up to sort of the surface, if you will, so that people start to see it and to start to recognize that. And it goes to things like, well, they're just going to have to manage when they come to our emergency departments. We have a really nice emergency department. What do you mean it's too noisy? It's too this, it's too that. Or I don't think it's really going to matter to them. Sort of undervaluing what someone's experienced. I don't think, for someone who's nonverbal, right? I don't think it really matters to them. That idea that we undervalue the experience of people with disabilities, underestimate them, and think more that we need to more favorably give resources to those that we deem to be more, I don't want to use the word necessarily deserving, but that there are people, they'll make better use of this. That's what ableism really is all about. In 2023, the National Institute on Minority Health and Health Disparities designated people with disabilities as a population with health disparities to support research addressing discrimination and other barriers to care. I should have said in my disclosure, I'm going to use every word that is banned these days. You can see it in my talk, right? That was supposed to be funny. Whoever laughed, thank you. That was supposed to be a little tongue-in-cheek funny, but you can see I use a lot of language, There was also something called the Heads Up Act, the Healthcare Extension and Accessibility for Developmentally Disabled and Underserved Population. This is a really important thing. I don't know what's going to happen to it, but it seeks to designate people with intellectual and developmental disabilities as a medically underserved population. So these are actually very important things that sort of suggest that people with disabilities are overall are underserved. So if I've done a decent enough job, you will understand now why the SAFE initiative was born. Because, and it stands for, again, it's about supporting access for everyone. It's an interprofessional stakeholder-driven initiative to establish a standard of practice in healthcare for supporting youth with neurodevelopmental disabilities. So I had sort of felt before we started this, like, you could just say, yes, we're an autism-friendly hospital, right? What did that actually mean? It just didn't mean a whole lot, did it? It just meant maybe you were doing something, but it didn't really mean you had any accreditation. Not that this does yet, but this is the goal. It just meant you were doing something that made you feel like you were, and it's not like it was a bad thing. It's not a bad thing, but there was nothing systematic about it. And that's why we decided to do this in a much more systematic way. And we decided to move away from the terms autism friendly because I think autism is narrow. We should be thinking about people with neurodevelopmental disabilities more broadly. And I just don't feel like this is about being friendly. I like people to be friendly, you know, right? It's nice when people are friendly. But this is not about friendliness. This is about safety and it's about access. And I just think it's very easy to trivialize something when we say, like, hey, we're friendly. I don't know. Maybe I'm not that friendly. Maybe that's why I don't know, but I just didn't care for that term. All right, so I'm going to tell you about what the SAFE initiative is. So we started by assembling a consensus panel. So those, again, are my partners on top, Dr. Augustin, Dr. Nadler, and we did this very, very purposefully. We asked people to sit on our panel across a number of different areas of medicine, psychiatry, neurology, there's child life here, we had hospital administration, occupational therapy, adult, people who do adult medicine, and most importantly, people across the country. We were very, very careful to ensure that we had a wide representation. We did not want this to be something coming out of like one discipline, that it would have wide acceptance and implementation. And honestly, most importantly, really, is we had the presence of parents and adults with lived experience who sat on our panel to inform the work that we did. So we had some phases. I just want to tell you so you understand where how this was developed and honestly the level of thought that went into it. We started off with having a 2-day public forum. There were 40 plus people who presented from across the country. They shared model initiatives, research findings, stories, and perspectives. Ellen Bannister, who you heard from earlier, was one of the presenters. It's a remarkable thing. I've been doing this, I feel like, for a long while. You get to thinking, well, I kind of know this stuff. I understand this. And when I listened to these presentations, it was quite eye-opening for me to hear stories in ways that I felt like I hadn't heard before. Hearing stories about lack of access, about medical trauma, in a way that I just felt like hearing stories like Ellen's that I had not really connected to over my career. So it was quite an eye-opening. I was really honestly very appreciative of it because I felt like there was a little piece that was missing from the work that I was doing. So after we had all of that and we looked at all of the research in the field, which by the way is spotty at best, it's growing, but it's spotty at best, looking at interventions within healthcare settings to improve care. We brought the panel together for a 2-day consensus panel meeting. We use this fancy term called nominal group technique, which basically says that we sort of, if you go through our circle, we generated what themes we had heard, we grouped them, we reviewed them, we came back and discussed them in the large group, and we just voted and voted and voted in a kind of voted until we reached consensus as to what we thought were the main issues and framed the right way. You know what, I just want to go back and, I guess I will go back. I want to just mention, by the way, that this work was supported by the Developmental and Behavioral Pediatrics Network, which is a 16-site group of academic institutions that is conducting developmental behavioral pediatrics research, and also AUCD, which is funded by HRSA and the Maternal Child Bureau, which is a little important to the story as we go on. But honestly, that work would not have happened without the support of these organizations. All right, so, and out of that came the publication, The Healthcare for Youth with Neurodevelopmental Disabilities, a Consensus Statement. Forget the QR code for the moment. I'm going to get to that at the end. This statement really is not a how-to. I wish it was. We don't have that yet. But what it is laying out what the key principles are. And I'm going to share them with you. You're going to see them and you're going to be like, wow, that's a lot of work for what you came up with. They're kind of obvious, and they are, but they hadn't ever been really written in this way and built through consensus, through a consensus process. But again, you might be like, wow, you spent a lot of time on something that I think we could have written in an hour. And it's maybe true, but this really was sampling the opinions and ideas of many different people. So this lays out a blueprint. That's what I'm going to show you. And then we're going to move into, well, what do you do with it? Because that's where the work ahead lies. Okay, these are the foundational premises. Again, you're going to read them and you're going to be like, huh, that seems pretty basic. But isn't it remarkable that we had to write it? That in fact, these are not taken for granted and they're honestly not implemented. So safe care is care that individuals understand and want, that is individualized and evolving with the changing needs of a person, that is accessible throughout the entire lifespan, equitable and respectful, and is defined and measured by patient experience, quality of care, psychological well-being of patients and caregivers, and not solely by narrow interpretations of safety and efficiency and remuneration. Those outcomes are important. I am not naive enough to think that measures of safety, efficiency, remuneration, payment issues are important, but they can't be the only ones. We've got to be thinking of some sort of proximal, distal, and broadly about what are the outcomes that we choose to measure our success. And safe care reduces or eliminates the risk of physical and emotional harm to people, including accident, injury, restraint, and seclusion, poor quality, inadequate, and incomplete care, and foregone care, which results in untreated healthcare conditions and increased mortality and morbidity. So these were the main concepts that we sort of covered in the SAFE initiative. And within each of these, there are a number of specific consensus statements about what we think institutions should do. But these are the sort of the big ticket items, if you will. Training, improving training, having training being more mandatory in its nature. Again, anyone who touches the healthcare setting, from the minute someone arrives to the minute they leave, should have some kind of training. And it shouldn't be the same training for everybody. Somebody who's working in a unit where they're seeing a lot of kids with neurodevelopmental disabilities is going to need more training, ongoing training, someone who has a much more limited connection. But training is an essential to start to think through. Communication, I'm going to show you a video in a minute. But communication about, ensuring that people have an opportunity to communicate in the ways they choose or need to, and that we are able to figure out how to incorporate that into visits. Access and planning. And a lot of this is about being proactive in what we do. And you're going to see, I'm going to show you, I hope, a fun example in a few slides. But this is about, before someone walks in our door, understanding what do they need. Let me ask you all something. When you go to the doctor these days, do you get like 1,000 messages before you go to fill out the form and update this? You're like, I did. And then you go in and you still have to do it again anyway when you get there. But don't you all get that stuff all the time? But we don't do that enough with our kids with NDDs to understand what is, especially for things that are elective, it's a little different. Although if they had it on record from their, when they go for their pediatric care, we would know. But before you go, what does your child need to ensure this will be a successful visit? What are their sensitivities? What accommodations do you need? Doing a little bit of pre-planning. And then thinking about when you're there, are there ways that the environment needs to be modified? And again, I'm going to talk about this later to ensure that this will be a successful visit. Again, about health equity and then policy and structural change. Because by the way, at the end of the day, we can all do nice individual things in your clinic, but if we don't have policies that bind it together and ultimately make this stuff mandatory, not optional, we really can't ultimately make lasting change. Okay, so let me tell you a little bit about Bob Williams. Bob Williams has a 45-year-long disability advocacy and policy career. He communicates using an alternative augmented communication device, and he is the co-founder of Communication First, which is a nonprofit that is focused on ensuring the rights, autonomy, and dignity of people with speech-related disabilities. Okay.
pediatricians, hospitals, and others who treat a youth who they believe require, but lacks effective access to AAC, should have the duty, and equally importantly, afforded the ready means to assure they access what they need. Simply put, ignoring a child's need, ability, and right to express themselves, to be heard, as well as respect, endangers their health, well-being, and life.
So could you all hear that okay? I'm going to just say his last sentence again. It's very powerful. He says, ignoring a child's right to express themselves, to be heard and respected, endangers their health, well-being, and life. It's a big statement, but I think there is so much truth to it. And all of you who are doing work in this area know that when children who do not communicate using words, have no ability to express themselves and express their needs, often will have more aggression, more self-injurious behavior, more acting out, more all sorts of things. And so when we sort of ask people to come into our healthcare settings and we do not find out what they need, and we rely only on caregivers, especially for older children, we really are in many ways, it's a big statement, but we really in many ways are certainly endangering their health and well-being. Okay, so again, if I've gotten you this far, you're sort of thinking, you're chomping at the bit to go, well, what should I do? So that's what we'll spend the last part of this on. So where do we start? Where do we start? And I always say we start by doing nothing. You start by doing nothing, taking no action. That's easy. We can all do nothing, right? That's a good thing to do, nothing. The first thing we need to start with is a mindset and an attitudinal shift. It all starts here first. It all starts with thinking about, just thinking about how is my healthcare setting set up? And how do we understand, if you will, the rights of people with NDDs within healthcare settings? Because we've often asked people with neurodevelopmental disabilities, if you will, to kind of check their disabilities at the door. But once you start to think about this and you go, wow, that's a bit of a no-brainer. If you get to that point, the rest of it flows because it's like you start to see something. It's like as if you never saw the color purple before, and then all of a sudden you see someone shows you the color purple. You know what happens? You see purple everywhere you go. You're like, wow, there's a lot of purple in the world. So that's what we start with, is our mindset and our attitudinal shift. And then we start to think about, well, what does safe mean in your personal practice, in your clinic space, in your institution, in your community partnerships, in your profession, with your trainees, in your presentations, your research programs, and your advocacy agenda, because it all kind of flows after that. The first thing you have to do is you have to obtain buy-in. Now, I know you guys, because I've been talking to you, there is some very exciting work going on at this institution. There really is. And so I think you've already laid this groundwork of obtaining buy-in. What I always say is sometimes you have to look under rocks and in corners to find out who your partners are. Because first of all, this is not a single provider, a single discipline activity. It's just not. Again, if we're trying to talk about policy-wide initiatives, institution-wide initiatives, you must have partners. So you have to find out who are your partners. And sometimes you find partners where you're least likely to think that you're going to find them, but this is a team sport, if you will. And, what I have found now, talking to people all around the country about this, is often the quality officers are interested because the safety metrics, and the nurses are interested because they're the ones often who are the frontline folks who are getting injured, and they end up with a lot of staff who are out or refusing to care for kids like this. So there's people all around who may have slightly different agendas and objectives, but can come together and understanding we need to do a better job. So once you feel like and again, just having spoken to all of you, I feel like you have laid the groundwork incredibly well here, which is very exciting. And then you want to start to look at what is the current landscape. And I feel like start with your strengths, because most institutions have something they're doing well. And start with that and start to think about, what are our strengths? What are we doing today? What exists? What are we doing well? Why is it going well? Who's carrying the torch? How do we get that stronger? What training does exist? Who gets trained and how often? Is it mandatory? Is it optional? Do people like it? What are the policies? Who's developing them? You can have the nicest policies, but are they being implemented? Who are your community partners? Are people with lived experience included? And I'll tell you, your biggest voices and advocates are going to be families and adults with lived experience because they care a whole lot about this stuff. What are the proactive strategies you have in place? What are they? How available? Are they embedded in your electronic health record? You have to click like 50 times to get to it. No one's going to do that. But are they easy to find? And how are you measuring success? Are you measuring success with sort of proximal small steps? Because those are important, and it can be very overwhelming and discouraging. If you're only measuring very big distal steps, you will miss that you're having success. So what are your steps along the way that you're thinking about? And I always say, start with small victories. Start with things that are going to feel good, look good, and give you some visibility. So I'm going to tell you a story, and it's a nice story, but it's I think, well, you'll tell me. So here's the story about this was at Boston Children's Hospital. I always say, I can take no credit for the story. Our child life people are the ones who drove this story. I just get to tell the story. So this was a patient. Going to the dentist has always been a challenge. For several years, we have unsuccessfully visited various dental offices and have attempted several strategies to convince him to have his teeth properly checked. No matter what we tried, he was always uncooperative. He would refuse to sit at the exam chair, refuse to open his mouth, and refuse to have his teeth cleaned. I think this kid was like, well, you'll see in one of the later pictures, I think he's like 10 years old. Have y'all heard this kind of story for kids, right? Neurotypical people don't really like going to dentists, do they? And often our kids with NDDs really struggle with this. Okay, so our child life people found out in advance by what I was saying, what does your child need to be successful? And they found out he had a strong preoccupying interest with Steve Harvey. Do y'all know who Steve Harvey is? I have to say, I did know him, but I didn't know him, so I wasn't so familiar with who he is. And he has that game show, Family Feud. Have y'all watched that show? Y'all going to go home and watch it. That's what I say when I give this talk. Y'all going to go home and watch it. I did go and watch it after that because I was like, oh, let me see who this guy is. And he is kind of a funny guy. So this is what they started by doing. They made a social story. Steve Harvey is going to the dentist. First, Steve will sit in the dental chair. The dentist will use a toothbrush and toothpaste to clean my teeth. And the dentist may use a little mirror to see the back of my teeth, right? And then on the day of the visit, they brought a big giant Steve Harvey. And what I want you to notice is what's going on with the kid. They are checking him. They are doing what they need to do. And now let's read what the parents said. With this support, he was able to have a proper dental exam and cleaning for the first time in his life, and he did not need to be sedated. By the end of the appointment, he was requesting to not leave. During our car ride home, he said a few times, I want to go back to the dentist. Now, how often does that happen? So it's a super sweet story, isn't it? I mean, that is a really lovely story. But I'm going to tell you, it's just so much more than a lovely story. And here's why. Kids who have undetected dental problems present in a number of ways. How many of you have seen kids who present with severe self-injurious behavior from pain of undetected dental disease, right? You all know this. Again, I know you guys know this stuff. And people do a lot of stuff and put them on a lot of medication and they still haven't checked the teeth, right? So that's one issue. Number two is there are kids who have not had dental care often present with very advanced dental caries and dental abscesses and a source of, again, high levels of morbidity. So it's so much more than just a sweet story. But what is so cool to me about this story is like, number one, people are always like, well, it's way too expensive for us to do all these accommodations, right? It's just so expensive. Now, you do have to have your child life people, but what they did was they just asked, what does your child need? Tell me something about your child. And with a little bit of creativity and ingenuity, look what they did. I mean, they made a $15 laminated, I made that price up, but a laminated picture of Steve Harvey, and I just think with a little bit of being clever and using some creativity and ingenuity, they were able to really turn things around. So here's a kid who leaves and says, you know what, I want to come back, as opposed to the kid who leaves after having been restrained and sedated and has medical trauma, and the parents like, yeah, we're not coming back for that again. That was awful. Okay, so what you then want to do is take those Steve Harvey stories and make sure that every clinic across your institution can have a Steve Harvey story and has the resources and the ability to make those stories come alive. So this was has been developed called like a Thrive Guide, just talking about how to, different kind of preferences that kids of different ages may need and things that you are going to want to make sure that you ask about and check about before they enter or when they enter your institution. Now, we do this at Boston Children's. This is called the Autism Seal of Approval. And basically, says that everybody in the clinic has gotten training in the support of patients with autism spectrum disorder. So that as one, and then again, remember, there's lots of turnover and this and that, and there's all kinds of questions about how much ongoing training, but that everyone in that center has at least been trained. And we've given this to more than 10 departments or sites within the hospital. And honestly, what's kind of amazing to me, really, is that the places that have had this take this very seriously and with a lot of pride. They don't get any more money. They don't get free lunch. They don't get anything except this, this designation. But people seem to really care about it, and it is a point of pride that particular units have really been interested in obtaining this kind of approval. We need to think about the physical environment. So, when the ADA was passed, I think in 1990, it really changed things for people. It should have changed things for people with disabilities everywhere, but it really had a big impact on people with motor disabilities, right? You can't imagine going into a hospital where you don't have, people having wheelchair access, not really, doors wide enough and elevators, et cetera, and rooms. But a lot of kids that we see with NDDs have either, less visible or invisible disability. But it doesn't mean that the environments aren't as triggering for them as they are, or difficult to access as it is for a person with a motor disability. It's not a comparison. It's, meaning one is more or less important. It's simply just saying that we haven't really thought about people with less visible disabilities in the same way. There are people thinking about this. Thomas Jefferson is doing a lot with, talking about the built environment. And there are people now writing more and more about creating sort of sensory-friendly healthcare environments. So what I would say is, look around at your sites. Look around at, what might be working in your environments, what's not working. Are there simple changes that one can make? And there are things that sometimes are really low-hanging fruit interventions, like dimmable lights, for instance, right? And then there are some that take a little more operational coordination, reducing wait times, preferential parking, things like this. And this is a perfectly nice setting, but it's a perfectly bright and pleasant looking setting, but it does look like it has very bright lights. And maybe you would take 4 of those chairs that are very, very close to each other and cluster them and put them separately to give somebody a little bit of a space. So it's trying to think, what can you do that's a big thing and a little thing? Where's your big victory and your small victory? Education is a very important thing as well. So this is really, I put this up to say, I think oftentimes we do have a lot of educational things at various institutions, but there are some national initiatives, and we don't really need to necessarily reinvent the wheel from the get-go. On the left is the niche curriculum, and this was developed by the American Academy for Developmental Medicine and Dentistry. This is about embedding developmental disability education into medical and dental school curriculums. And again, I told you the ACGME is very, very serious about doing this across, so I am quite sure we'll be hearing more. The Institute for Exceptional Care on the other side is really building a web library of vetted continuing ed materials that are focused on developmental disabilities. So I think when we are aware of some of these things, we don't have to, start from scratch. That's so daunting, isn't it? And then I always say, what do your talks look like for all of us here, or many of us here who may give these kind of lectures? Do we talk about this issue? Do we talk about healthcare access? Do we talk about morbidity and mortality? I know I've gone back and looked at my talks to see in my sort of basic lectures, what am I saying? Should I be changing that a little bit? This is sort of just an interesting thing that was developed by the Autistic Doctors International, and they just laid out something they called a SPACE framework. Honestly, we've really talked about it already, but it's a nice sort of acronym: sensory, predictability, acceptance, communication, and empathy. And sort of, I think we've really talked through a lot of these. Predictability, though, being, telling people what you're going to do before you do it. We kind of should do that for everybody. And in fact, by the way, a lot of the principles we talk about in SAFE are very universal principles. They are very universal. The truth is that people who are neurotypical are able, they may not like their healthcare experience, but they're often more able to pivot and to accept and to adjust. But they may not be happy. So predictability, again, we've talked about, all of these, but I think that the underpinning of this is sort of, individualizing care for people, recognizing it's not a one size fits all, and kind of accepting people for where they are and sort of meeting people where they are, and trying to ensure that the experience that we deliver to people, that we can give healthcare in a way that feels kind of empathic and that we are partnering with people rather than demanding that they come to our sites and again have to modify behaviors to fit the way we do things. So it's a little give and take. I'm going to speed through because I want to make sure we get to a few questions. We need to take all that we're doing and build it into a research and quality improvement portfolio. It's so important because you guys, for instance, could be doing great work, but if you don't study it and you don't publish it and you don't write about it, we cannot establish what standard of care, best practice, that I think ultimately what we want to do is truly develop accreditation. So that when we think about all the ththings that hospitals get accredited for, this would be one of them. So we need to publish, we need to study, and we need to be, just use a critical eye at everything we do to ensure that the interventions we're doing that may sound great, but if they don't show that they're great, that we move on or we tweak them and modify them. We need to involve our communities. It needs to be bi-directional. Your communities, and as I said, your parents and adults with lived experience are your best, often, and loudest voices. Partner with them, ask them, is what we're doing makes sense to you? We really need to be a bit humble about some of these things, and we need to inform them of what we are doing so that we have a bi-directional kind of relationship. And this one's a little hard to talk about because I think, legislative advocacy, I don't think this is our moment. I'm going to show you in a sobering way on one of my last slides. But I will say that the Autism Cares Act of 2024 was passed. It is responsible for much of the funding for research, for service delivery, for our training programs, and it was passed this year. So we need to figure out how to ensure that we are still, in good times and in difficult times, the voices of people with disabilities. So I'm going to end with a few quick slides and one more video. In conclusion, I think we need to develop proactive partnerships that involve everybody. We need to expect and advocate for systemic changes that may include some upfront financial investment to support long-term improvements. And I always say, but you do not know. Everyone's like, but it's going to cost a lot. And the answer is you do not know that you are not actually going to save money when you have less staff injury, when you have reduced length of stay, when you have people presenting with less acute care and less advanced disease. You actually don't know that you won't save. But I will say there is going to be some upfront investment. But if we think it's important, then change has to be an expectation and not a suggestion. So this is, I'm going to add with two last things. This is Patrick Forgy. Patrick is an autistic adult. He is the research coordinator and serves as the self-advocacy discipline coordinator at the LEND Institution, at the LEND program in Indiana.
Not every autistic person has the same issues. Similarly, not every autistic person needs the same accommodations. Not every autistic person wants or likes the same things. Find out what the person in front of you needs, you want, what they like, and build the care and the plan around it.
So I think Patrick says that really well.
Not every autistic person has the same.
How do I go on to our next slide? There we go. So I think Patrick said it really well. Now you can look at our QR code. And now I'm going to tell you, I'm going to leave you on a sobering note and hopefully an uplifted note to finish. So this QR code, if you had gone to our website, which was the Safe DVP website, you will go there and you will see we are no longer there. So the federal government has taken it down. We are no longer considered to be okay because we are dealing with, I don't know what, better care for people with disabilities, but we are no longer there. And the work that we started that was funded by the federal government has also been put on hold. And so that's a very sobering and serious note. But I will tell you, I think we still have work to do and we can do it. And we're looking to find funding. I have no idea where that's coming from. But I know that there's a lot of people around this country who care about this. And I know that because I've just talked to so many people who really care about this. So we're going to move forward and we'll figure it out. And our goal for now, if you look at our QR code or scan it, is that we are going to form a Safe Champions Network. And we are going to be bringing people together. And we actually have one plan for Monday, May 5th. And if you join us, you are under no obligation to do anything. You don't need just to show up. And our goal is just to bring people together across the country who are parents, who are adults with lived experience, clinicians from all over, to at least just share our experiences, to figure out our next steps, to keep this moving. Because I know at some point we will figure out a way to find additional funding and just keep moving forward. So I hope you'll join us. And I thank you for the time. And I hope we have time for a few questions. Thank you guys very much. And I don't know if people online can ask.
Yes.
Oh, you are? Good. Thank you. Okay. Anybody have questions? Go ahead, Dana.
So I have a question. In this whole process, you talked about at the beginning that, you're sharing some information, or you could have written this in a day with what we all know. But
it took us 3 years, but yeah, go ahead.
Right. But in this, my question is, was there anything that was surprising that you're like, oh, that wouldn't have been something that I thought
The thing that surprised me the most, it's a great question. And the first thing that just popped into my mind, the thing that surprised me most in this was really didn't understand the amount of medical trauma people experienced. That was very eye-opening to me. I don't know. I just was very eye-opening. I don't do a lot of inpatient care, and maybe that's why, but I just didn't really get that. Does that help with that?
Yeah, there's a comment that maybe time to enhance home-based care.
I think that's a great point to advance home-based care. I'd like to know more what they're talking about. Is that for home-based medical care, home-based what? Tell them expand. Other comments, questions, ideas? It's too early in the morning. Y'all are just waking up on Monday morning. And by the way, you get an extra kudos to my butt for being here so early on a Monday morning. Go ahead, Ray. House calls. Yeah, what a nice idea. Wouldn't that be nice for all of us? But yes, it's a great idea. I don't know the feasibility of these things, but I think those are sort of cool ideas. I love the idea of thinking a little, if you will, out of the box in the way of thinking, how do we best deliver care? I do always say, though, the one thing this has come up in other places is I don't want us to develop I think we want to have coordinated care. I don't want to have parallel care. It's never a good thing when one group is getting something very different than another group, because it's often an opportunity to give non-equivalent care. But I love that idea. I love the idea, like if someone would do a house call first and do get some of the information, or do a Zoom call, or I don't know, there's all kinds of things to do. Yep. Yes.
That was excellent. So, you made a comment about the idea of all the text messages that you get for visits.
Yeah.
Which some people just don't do any of them, right? But some people will do them.
Mm-hmm.
So I don't know if there's suggestions you have something in, and probably for all kids, especially for our technology, for all of the sciences. What's your topic? What do we need to do? What is really helpful? Because I think exactly your story, like how do you get that from them, especially in short time frame? We only have a few minutes with them. How can you maybe have some families who are really good at it prep us?
Yeah, great question. And I'm going to answer it with like two comments. Number one is we need to be getting the information about what people need in advance, like during their pediatric visits, that feeds into our EHRs so that it's part of that. Or during a time when they're not stressed and you're doing a visit, like we have a behavior support plan that you say, hey, let's fill out your behavior support plan so that under more stressful moments the kid presents to the ED, the behavioral support plan is there already. But I think you bring up something that I think we need to do more work on, and that is looking at the interface between technology use and kids with NDDs in general. You know, like how much are we using things like text messaging and all these things? It's way beyond my scope, but I think there's, you know, when you look at the number of apps that are out there around like mental health issues, like, are we really using it? Could we leverage that to be doing things like more texting to get that information that, for instance, feeds into our EHRs? That's kind of a cool idea. Yeah.
So my question is somewhat of a clarification.
Please.
You said restraint is frequently used as a response to an ASD individual.
Yes.
Yet, as an ASD individual, frequently when emotions get high or lack of being able to communicate comes clearly, the first thing we do is use our arms. If you're restraining kids, aren't you adding fuel to the fire?
Yeah, I think it's a good point, you know, but I think you bring up something interesting. So if someone who is appearing maybe agitated is using body movements, that is often misinterpreted as being an act of aggression, right? And instead of potentially using a de-escalation strategy or recognizing this is not an aggressive act. But by the way, there are times where kids can be aggressive, okay? So we don't want people getting hurt, right? I mean, we just don't want people getting hurt, but employing de-escalation and even asking someone, hey, I need you to blank. I need you not to wave your arms as much. I think you can pretend, but those are the kinds of things, exactly. Misinterpreting behaviors, learning to de-escalate, talking it through, all of those kind of things before we move into. But what drives it? People get scared. They just do. They get scared. Our staff gets scared, and people have gotten hurt. It would be incredibly wrong and naive of me to suggest that that's not a real issue. Probably most of us in this room have had moments where patients have kicked you or I don't know what. Hopefully nothing, you know, so terrible, I hope. But we know that things can pivot really quickly. But I think you bring up such important points. Yes.
I have a little bit of a loaded question that
Okay. Okay, it's always fun to end on a loaded question that I can't answer. Thank you for that.
So I'm trying to think about this incredibly while also trying to autism, I know that there is an initial period and I'm wondering, in addition to education,
Yeah.
are there additional things that we can do to make sure our care providers have information while also reducing bias that might increase?
It's an incredible, it's not a loaded question. Did you all hear that question? It was, you know, it was an incredibly important question. And we used to, I'm trying to remember, it was before I came to Boston Children's, that there was sort of something people would put on the door that would suggest somebody had a neurodevelopment, and parents found it very stigmatizing. So they changed the symbol to something else. The name initially, I think, was called like a Cautions B. I don't know why they came up with that. It was before my time, Cautions B. It was a very stigmatizing thing. And there is definitely, it's 100% that you could see that in a chart and be like, I don't, 100%. So there's an education. Now we have what's called a behavior support plan. it still can be stigmatizing, but I think I love that point. It's not loaded at all. It's always looking at the unintended consequences of what we do and making sure that what we do to be helpful doesn't cause harm. So you can't do these things without pairing it with education. I think I love that point. I think it's a brilliant point. I don't know what time you go till, but it's now time for you all to get on with your day and start your Mondays. Thank you all very much for your attention. I appreciate it.